This clinical webinar series is now at Season 5, Episode 2. My name is Aiman,
And my name is Farzana.
and we'll be your moderators for this afternoon. It's a pleasure to have all of you join us. This webinar is organized by Department of Emergency Medicine of Hospital Chancellor Tuan Kumukris. For your information, we also collaborated with several esteemed organizations to ensure the success of this webinar, namely Remote Evaluation Consultation Service, Malaysian Society of Toxinology, Special Interest Group in Clinical Toxinology, College of Emergency Medicine, Emergency Physician, Academy of Medicine Malaysia, Malaysia Biodiversity Information System, National Poison Center, University of Science Malaysia, and ToxEd.
Before we begin, here are a few housekeeping notes. Participants are most welcome to turn on their cameras. Please keep your microphone muted throughout the session unless invited to speak. Use your full name as your display name for identification. Kindly post your questions in the chat or Q&A box. They will be addressed during the discussion session. Please do not interrupt the speaker and wait for the moderator's cue before speaking. Recording, screenshots, or screen capturing are not allowed unless officially permitted by the organizer. Maintain professionalism and respectful communication at all times. For technical issues, please rejoin the meeting or inform the organizer via the chat. Also, a gentle reminder that there will be a Kahoot quiz session at the end. Do stay tuned and stand a chance to win the grand prize, which will be awarded to the champion.
Now, join me in welcoming Dr. Azlan bin Muhammad, Emergency Medicine Specialist at Hospital Chancellor Tuan Kumukris, to deliver the welcoming remarks for today's webinar. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to everybody. Thank you very much for inviting me to give a welcome remarks. It has been a pleasure to have this conference on toxicology. For medical students, it's an introduction which I don't think can be offered in any other postings, which specifically for this toxicology session. And it's actually will be a good exposure for them. And actually also the treatment, the patients which are actually involved in this toxicology things are actually very important. And it will be a pleasure and it will be a good exposure for the students to learn. And I don't find any other place where actually this can actually be included in other any postings other than in this session. So I hope all the students, and thank you very much also for the panelists. You can see here the name of Dr. Tinesh, Dr. John David. And thank you very much also for to Professor Khaldun for actually, he's the one who actually organized these things and persistently makes it an effort for every attachment to include this session for the students. Okay, again, I'd like to thank you everybody, and hope this can go well and be educational and benefit for all of us. All right, and thank you very much. Can pass it over to the speaker.
Thank you very much, Dr. Azlan, for your insightful and encouraging remarks. Your words inspire our journey toward becoming a better clinician. Now, let's take a moment to introduce the team behind today's webinar. This webinar is proudly organized by the Year 5 Emergency Medicine posting under the guidance of Associate Professor Dr. Ahmad Khaldun Ismail, Emergency Medicine Specialist at Hospital Chancellor Tuan Kumukris. We are truly grateful for his invaluable guidance and support in making this session possible.
Now, let's get to know our panelists for this webinar. Today, we are fortunate to have with us 4 experts who will help us explore this theme through real clinical cases. Let me introduce Dr. Ong Sook Har, Clinical Toxicologist and Emergency Physician, Hospital Tengku Ampuan Rahimah, Selangor, Malaysia. Next, we have Dr. Gregory Cham, Senior Consultant Emergency Department from Ng Fong General Hospital, Singapore. We also have Dr. John David with us today, Vice Chair for Training, National Poison Management and Control Center from University of the Philippines, Philippine General Hospital, and Dr. Tinesh A, Eravi, Emergency Physician from Hospital Tengku Ampuan Afzain, Kuantan, Pahang, Malaysia. Thank you all for being here with us today. Now, Aiman, I believe we can officially dive into clinical toxicology. So can you please introduce to us what clinical toxicology is?
Yeah, sure. So what is actually clinical toxicology? Clinical toxicology is a medical subspecialty concerned with the diagnosis, clinical assessment, and management of envenoming and poisoning caused by animals, plants, mushroom, and bacterial toxin. So what is toxin? A toxin is a poisonous substance of biological origin produced by living organism that can cause harmful physical effect when introduced into a living organism. Since envenoming and poisoning was mentioned, what is the difference between these two? Envenoming refers to the active injection of venom into a human through a specialized delivery apparatus such as fangs, stings, spines, or nematocytes. Venom itself is typically introduced parenterally, example via subcutaneous, intramuscular, or intravascular, and contains biological active toxin designed to immobilize prey or for defense. Poisoning, on the other hand, refer to toxic effects following exposure to a poison that is passively encountered without an injection mechanism. The toxin usually enters the body via ingestion, inhalation, absorption through skin or mucosa. Okay. Before we go further, I'd like to clarify an important concept that is often misunderstood: the difference between venomous and hazard level. An organism that is equipped with venom is called a venomous animal. What defines a venomous animal is not how dangerous it is to human, but the fact that it actively uses venom either for prey capture or defense. Now, the effect of venom on human depends on several factors. Most importantly, it depends on the potency of the venom and the dose of venom that actually enters the body. Because of this, the clinical severity of envenoming can range widely from potentially deadly, dangerous, or not dangerous and harmless. This leads to an important takeaway. An animal is either venomous or non-venomous. There is no scientifically meaningful category in between. Terms such as highly venomous, moderately venomous, or mildly venomous are not accurate descriptors in toxicology. They tend to confuse the concept of venom delivery with clinical hazard. Instead, what we should be discussing in the hazard level to human, which is informed by venom, dose, route of exposure, and the circumstance of the encounter, not whether the animal is more or less venomous.
I see. So moving on, before this webinar, we have conducted a survey among 42 final year medical students in the current emergency medicine posting at UKM to assess their awareness and confidence levels in clinical toxinology. So based on the survey, as we can see here, almost half of the respondents claim that they are aware of what clinical toxinology is about. I think this might have something to do with us joining episode 1 conducted by our peers 2 months ago. Moving on, in this section, as you can see here, we compared the responses from the previous set of respondents for episode 1 with this current set of respondents for episode 2. For each segment, the upper row represents data for episode 1 and the lower row for episode 2. So in terms of confidence in providing information on the appropriate safety and health-seeking behavior regarding toxin injuries, majority of the current respondents reported to feel unsure about 3 components, namely toxin-related injuries as medical emergencies, various emergency services for toxin injuries, and also role of RECS. And as for the appropriate healthcare facilities after toxin injury, majority remains at neutral. Next, in terms of confidence in sharing knowledge on the appropriate safe and health-seeking behavior for toxin injury, almost half of the respondents felt neutral in identifying the common signs and symptoms of toxin-related disease and also various sources of natural toxins. However, they felt unsure for the other 3 components, which are the appropriate first aid measures for acute exposure to natural toxins, emergency hotlines, guidelines, and resources for managing toxin-related diseases, and also appropriate antivenoms for treating envenomation in Malaysia. And lastly, in terms of confidence level in providing instruction or information for toxin-related injuries, majority felt neutral in 3 components, which are identifying potential toxin injury, emergency procedures in cases of suspected toxin exposure, and also important history details that need to be obtained following a toxin injury. And majority felt unsure to provide information on how to administer appropriate first aid for toxin-related injury and where should one be transported after a toxin injury. So in conclusion, from this survey, we can highlight more on the role of various emergency resources and services, including RECS in toxin-related injuries, how to administer appropriate first aid measures for acute toxin-related injuries and subsequent important managements, and also appropriate antivenoms for treating envenomation in Malaysia in the discussions later in our cases.
All right, let's jump into our favorite part. So in this webinar, we are going to discuss a few clinical cases with our expert panelists. For your information, these are the actual clinical cases in Malaysia that were referred to RECS in the past. Without further ado, let's begin our first case discussion. Alright. Okay, our first case. This case involves Mr. H, a 39-year-old female with underlying antiphospholipid syndrome on warfarin. The incident happened on 27 August 2025 at Tiram Sungai Merbok. At the time of the incident, the patient was removing dry leaf from flower vases when she did not notice a snake nearby. She suddenly felt a bite over the dorsum at the base of her right thumb, and immediately after that, she noticed a snake on the ground. There was only one bite at the base of the right thumb was at the affected site. Okay, maybe I would like to ask Dr. John. Is there any other history you would like to know?
Right. So maybe was there documentation of the snake?
All right. Okay.
If there were pictures or descriptions done during the present illness, the bites.
Yeah, that's a good question, Dr. John. So let's dive into it. So actually, after the incident, the patient, the management were decided by RECS. Given the patient anticoagulation status, the bite location, and the potential risk of inflammation-related bleeding complication, so a tourniquet was applied using a piece of cloth, which remained in place for approximately 1 hour. This was subsequently removed in the ambulance during the transfer of the hospital. In addition, there was a topical application of getah betik over the bite site by a co-worker prior to presentation. Spontaneously, the snake was captured alive and brought in, which later allowed for animal identification. Okay, so I would like to ask Dr. Tinesh. My first question is, maybe you can share a little bit what is actually getah betik and how does it work, especially in this situation. And do you mind also share about what usually is the common type of snake in Malaysia?
Okay. Thank you for the question. First of all, getah betik, I would like to translate it. It's a papaya latex application towards the snake, but it's one of the many traditional method, or it's a non-clinical method used by the commoners to apply at the bite area, which they believe it neutralizes the toxin from the snake bite. Which there is no clinical evidence to say that it helps to neutralize the venom. So your second question is, you asked me about the common snakes that we encounter in Malaysia. So some of the common snakes are the elapids, the kraits, and also some of the sea snakes. Okay, so we commonly encounter some of the Naja species such as Naja cautia, Naja sumatrana, and traits like those bungarus species and also sea snakes. So those are some of the common snakes that we, and also the pit vipers, of course. So these are the things that we commonly encounter in Malaysia.
Can you go back to the first slide? So here you can see it's Sungai Tiram Merbok. Where is the location? Actually, we state
At Bedong Kedah.
it's in Kedah. Okay.
Yeah,
All right.
in Kedah.
So Kedah is northern part of the Peninsular Malaysia. It's a state on northern part of Peninsular Malaysia. So they have their own list of indigenous snake species. So most of the time that we encounter is going to be the Malayan pit viper from this, and also the Naja species. There are two Naja species. They have both of the Naja species in their state. Okay. So anybody else would like to ask any information? the speakers, the panelists, Dr. Greg, Dr. Sohar.
Hi, I'm Dr. Sook Har here. My apology, I couldn't on my camera. So some other question maybe involve, I would like to ask whether was there any manipulation done over the bite site or wound? What did the patient did, and how did actually the patient like go to the hospital? Yeah.
Panelists, how did the patient go to hospital?
Actually, there is no specific medication was given on the right side, but he was transferred to the hospital using ambulance. But during the hospital, they were given. There will be. I will explain later lah. There's a few treatment was given lah. But during the incident, there is no specific medication except the getah betik, the papaya latex.
Okay, thank you so much.
Okay.
Some other questions that maybe we would like to know is like, what is the pain score of the patient? Those are the things lah. And also, anything else was done to the affected part? I mean the bitten part of the patient, the tongue. Was there any like immobilization other than the tourniquet and the getah betik or the papaya latex application? Anything else? And yeah, that was my question. Maybe those are the informations that we need.
Okay. Can we see the next slide? Yeah. Dr. Greg, anything else you think that we miss in the history?
Hi, just a few things. Was she working in the place? What was her occupation?
She was removing dry leaf around that area.
Oh,
Suddenly
okay.
fell.
Yeah. So I assume the bite occurred in the daytime. It's not a nocturnal snake.
Yeah, it is.
Yeah. I assume she's right-handed.
That one,
Yeah, most likely.
most likely.
Okay, it's all right.
Okay.
Alright.
Yep.
So I shall continue. So this is actually the snake that was being captured. Maybe I can have Dr. Ong, based on the appearance of the snake that was captured, what species do you think this might be? Is it venomous? And actually how to differentiate between venomous and non-venomous snake?
Anybody else would like to try to identify? It's a dark-colored snake, and there's some white stripe or white line
Yeah, I
on
think
the dorsal.
not so
on the
sure.
snake.
I'm not so familiar
Mm.
with snakes in Malaysia, but is this chimeras really?
Yeah. Okay, so if let's say we get something like this, right, from the consultation, what can we do to improve the visual? What can we ask as the consultant? What normally we will be asking the doctor to do? Anybody? Any idea to improve our visual of the specimen?
There's actually suggestions on better getting some visual aid for identification.
Yeah. So
So
how would you ask the doctor? That's the
right,
question. These
yeah,
are
like
our junior doctors. Yeah. So
So there
are
are
we going?
actually four parts that is usually checked. So number one, of course, first and foremost, it's very dangerous to bring the snake in the hospital. So
Yeah.
if you can
Okay.
actually get some pictures and you can zoom it, that's actually better. So in taking those pictures, if you can actually take a picture close shot of the head,
Mhm.
and then you can also see the dorsal and the ventral side. And in this case, like for this types of snake, it will be actually beneficial to also take the side because there's actually characteristic patterns that you can actually see for it to be easily identified.
Right. Okay. Anything else would like to add on? If you notice the patient managed to get the snake into the bottle, right? So that is interesting. How and who actually caught the snake, put into the bottle. So yeah, maybe Tinesh or Greg have any idea how we can visualize instruction to our juniors so that we can visualize the snake better? Are we going to ask them to remove the snake from the bottle and take a picture? So what's the important question
I
you want to
I
ask?
think, Prof, if the snake is dead, we not sure
Ah,
what happened to the snake. But
okay.
I mean, of course, if the snake is not dead, it's very unsafe to ask them to attend to the snake. At that point,
Exactly.
we might end up having more patients then.
Yeah.
I think if the snake is dead, then it is fair to ask them to give us the entire snake's picture from head to tail. Of course, if they're able to, give us the picture of the snake, then we probably appreciate if the person who consult us give us a certain view or certain image that we want, so that we can get we can roughly have an idea what could be the most likely species. So some of the views that could be helpful is, of course, the full body view to see any like patterns and all that. And also the head view. For example, if you're thinking of pit vipers, then the triangular head and all that could give us more clue on the species. And of course, the side view to see the patterns and all that, and also the dorsal view of the snake, which is the top view, to see the patterns. So these are the some of the things that can give us rough idea on the species. And of course, if it is they unable to take out and all that. So if they really saw the snake, then we can give them the land snake gallery pictures, so they can actually show us the likely species that beat them, so we can have an idea of what likely species actually attack the person.
Okay, that's very interesting. So first question is the snake still alive or dead? Is there any
Yeah. You see, the snake was captured alive and brought in.
so it's alive, right? Okay, so definitely you wouldn't want them to remove from the bottle. Okay, in the hospital. So that's a no. So what can we do? Maybe Greg, you have any high-tech idea on how we can get a better picture of the snake?
Okay. I agree, like we need a better picture.
Yeah.
Um, if there's no way of handling it safely, then I think we attend to the patient and see if
Yeah.
what sort of symptoms the patient has. Whether
Okay.
there is a hematotoxicity that is occurred,
Yeah. Okay. So you're talking about the syndromic approach, right? But
symptomatic.
there is a specimen here, and it's still alive. Anything that we can do? I mean, it's a waste of having the specimen there without being
Right.
fully
Actually,
identified, right? There's a big effort from the patient to bring the snake in the bottle. So how can we approach this? Any tips or idea?
yeah,
Maybe.
what we do in the Philippines, we
What do we
have
do in the Philippines?
we have some of our collaborators that we can
Ah,
actually ask us to get the specimens. For example, if for some instances we have this live snake, for example, in a certain institution, the Research Institute of Tropical Medicine has its own veterinary services that can actually identify the snake. So we safely hand the specimen over for proper identification. Or sometimes we do
yeah.
collaborate with the Department of Environment and Natural Resources because they have the capacity to identify the snakes and handle the snakes to be released in an appropriate setting. So those are
Okay,
some
so
of the things we
yeah,
do.
but that would be quite a distance to transfer to
Right,
RITM,
right.
and it will not give us the identification there and then, right? So it takes time. But if we know if it is anything that we can do, maybe anybody encountered this situation when you're being
Uh,
consulted? The specimen is there.
is
You are
the
there.
bottle big
Yeah,
or
it's a
is it
water
small?
bottle.
Small.
The water
It's a
bottle. You can see the
so it's a
hand
big
holding the water
it's a
bottle.
big
Yes.
it's a fairly big. So maybe if
It's
you
a
can slightly spread it
it's a half a liter bottle, I think.
half a liter, right?
Yeah, so it's not that big.
Some maybe if I were to do it, although I don't know
Mm.
how I mean thick
Yeah. Any
bottle.
creative idea?
Yeah. Maybe you can spread somehow disturb the bottle for a bit so that you can
You want to
you can
agitate the snake.
agitate the snake so that you can actually show some of the features not in this crumpled picture.
Okay. So this is how Rex comes in. So what we give instruction, we are not there, right? So we are remote. So what do? We said do not agitate the snake. Okay. Don't shake the bottle or whatever. Just put it on the table. Open the cap of the bottle. The snake is down below, right? It's not moving, right? So just open the cap. Put your camera top of your camera on your mobile phone on top of the bottle, and you will see that it will give a better view of the snake from the top there. So just snap a couple of pictures and then close back the bottle. So you get a clearer picture of the snake from the dorsal view, and that is actually sufficient enough to complement this picture. Actually, from just this picture, Rex already identified the species. So, but we just want to have a better, nicer picture, then we can. But otherwise, don't ask the doctor to remove the snake from the bottle. That's one. That's one way.
Very
One
dangerous.
method that we can get the quick picture, right? Second is that we can also ask our colleagues in the what do you call this fire and rescue, or those who are actually workers that handle the snake to actually consider removing and rescue the snake. So they will, let's say the snake arrived to hospital. So the fire and rescue or the what do you call civil defense will be called, and they will actually collect the snake from the hospital. So when they are doing that, you can actually ask them to identify the snake for you or remove the snake for you to take a picture of the snake before they put into the container for safe handling. Okay, so we have experts that we can ask to do that for us. So this is in Malaysia. I'm not sure about in Philippines or Singapore. Maybe you have people come to the hospital to collect the live snake. What about Singapore, Greg? Do you have people that can come to hospital to collect the snake, or what do you do with the snake if they bring the live snake to hospital?
Oh, if the snake is alive, we hand them to the police.
Okay, so
Yeah.
wow.
The zoo used to take the snakes, but now they don't.
So the police will transfer them to the zoo, I assume.
Yeah, they do. If
But they don't identify for you there.
No,
and
they
right?
can't. Yeah,
Yeah.
but they can release the snake lah. The police might do that.
Okay, so yeah, that's interesting. Put the snake under custody. Okay. So yeah, so this is the thing that we do. So just from this picture, any of you can maybe identify the species? Not the genus, just the species straight away. And what are the telltale signs, if you can share? Maybe David, John, JD may not be able to because it's not your local specimen, a local species. But Greg definitely can.
But I think this is Triberosugu.
Yeah, it is a Trimeresurus, but which species? So Trimeresurus is the genus. Just from this angle. So this is something that we do also. Ask the doctor treating the patient. We give them our ebook on the land snake of medical significance in Malaysia. So we ask the doctor to identify, okay, to guess or to select which one that in the ebook most resemblance to this picture of the snake, and we do like a small quiz. Anybody else would like to try, and so on. Yeah, so it's a kind of fun during the consultation. So like what we are doing now. So anybody would like to try? Guess. So we sometimes the student, the doctor show the picture of the book to the patient, but that's not appropriate because the specimen is already there. So the doctor needs to take the responsibility to identify it. Okay, not ask the patient. So if the snake is not there, then only you show the ebook to the patient so that they can identify which maybe similar looking snake that bit them. Okay, but now the snake is there in the hospital with the doctor, so the doctor have to try to identify. So from the ebook, what they think, and then of course with consultation to Rex, we can verify. Yeah. So another thing is the why I asked in the beginning, where was the location? The location was at Sungai Dua, is close to the river and by this near to the shore. Yeah. If you Google, so what we did also, we Google the incident location. So that will tell us where exactly geographically position the location. We drop in and we can make a guess what type of species are there in that locality.
Based on the history and also it looks more like a mangrove pit to me.
Okay.
Based on the
Which feature on this picture shows you that most likely is a mangrove pit viper?
I don't know, the part that we are looking at, probably the head looks a bit triangular there. That round thing on the right side of the bottle,
Yes.
could be a rounded head, rounded triangular head of
Okay.
pit viper
Yeah, all
characteristic.
pit viper are triangular head. So, but
Yeah.
why is it a shore pit viper
The brownish
or mangrove pit?
reddish appearance of it shows like it's probably a mangrove pit to me, bro.
Okay, all right. Okay, Greg, this is in your vicinity. It's in Singapore. So, what do you think is the feature here that you can say this is a mangrove pit?
Well, maybe a look at his eyes.
Okay, all
If it's
right.
red,
Okay. You can ask the doctor to look into the eye. Eye to eye with the snake. Okay,
yes.
look at the color. Okay, so just to tell you that is correct what you're pointing out, the color, the eye, and also the here you see the white dotted line on the stripe on the lateral part of the body. That is also a typical feature of a mangrove pit viper. Mangrove pit viper typically has many other coloration differences in coloration from north to south. So what you have in Singapore, the color will be darker, something like this, or even almost completely black. But in the northern side, it becomes a bit lighter, more greenish. Okay, somewhere this case is in Kedah, right? So this is kind of a typical coloration for that particular area as well. You go down to Perak, it's a bit more yellowish in coloration. So it is very strange in terms of the color of the snake throughout the west coast of Peninsular Malaysia. You can't find this snake anywhere else on the east coast. Maybe up down to Johor on the east coast to Mersing, you can find it. But north of the east coast, you can't find. Definitely not in Sabah and Sarawak as well. Okay, so geographically, it is Sound, which is on the west coast, close to the sea, near the river, and also discoloration patterning. So this is actually a verified identification just from the picture, verified identification by Rex to say it's a mangrove pit viper. Okay, Trimeresurus purpureum maculatus.
Yeah, actually, Prof. Cal, what you mentioned something interesting because most trimeres, I identified it in the genus level because most trimeresurus will have the characteristic white, sometimes yellow, sometimes red, sometimes white. So this is maybe this species, this is white. Because Tropidolimus will also have the characteristic triangular head. But it's only in trimeresurus that you would have the characteristic pattern in the side. And very interesting.
Yeah, so the scalation also can be different between species. Okay, so for example, Calosalasma rhodostoma, the Malayan pit viper, the scales on the top of the head are not the small, tiny scales. It's actually quite big scales on the head. Okay, that's from the Calosalasma genus. But for the Trimeresurus genus, the scales are small scales. So that's also another way if you want to look at escalation to differentiate. But there's only one here in Malaysia, Calosalasma species. So it's pathognomonic kind of looking at the scale on the head, triangle head is already Calosalasma. If you want to differentiate between the Calosalasma and this mangrove pit viper, you're correct. Both are actually present in Kedah, and people can get confused between the two species. Many a times we get doctors consulting regs saying that this is a mangrove pit viper. Okay, so luckily they consult us because we can give the identification correctly, and whatever finding after this in terms of the syndromic approach, we can suggest the most appropriate antivenom for this patient. Okay, so it's different between the antivenom for Malayan pit viper and also for the Trimerosaurus species. Yeah, so that's why identification is considered as vital in a way. If you have the specimen here, right, we are adamant to find out the species to identify. Okay, so all efforts are made for the identification for this. Okay, so can we move on? What else can we continue discussing?
So answering the question the Dr. Tinesh asked before, so this is what upon our assessment, so in the emergency department, the patient was alert, pink and not tachypneic, with good pulse value, and the pain score is 2 over 10 only. Her vital sign is BP is 165 over 112, and with heart rate is tachycardia 103 over 103. Respiratory rate is 20 beats per minute, SpO2 and temperature is normal. So upon examination, so in this patient, there is presence of single fang mark at the base of the right thumb, and presence of swelling extending up to the wrist. There's no active bleeding, bruising, ecchymosis, thermonecrosis. The compartment was soft with full range of motion of all fingers. Sensation was intact, radial pulse palpable, capillary wave time is less than 2 seconds, and rate of proximal progression is 3 cm. Otherwise, there's no neurological symptoms such as no ptosis, no ophthalmoplegia, pupils equal and reactive, no trismus, no cranial nerve palsy, and no dysphagia. There's no bleeding tendency, abdomen soft non-tender, with no rashes or urticaria. All right. Let's dive further about the lab investigation. Upon investigation, ECG was normal, the sinus freedom, heart rate is 91 beats per minute. The full blood count was also normal, with HB, total white cell, and platelet is within normal range. However, when we dive into the serial coagulation profile, in this patient, actually I would like to ask to any of the panelists, you can see in this patient with the background of antiphospholipid syndrome, and this patient is on warfarin. You saw initially the patient had mildly prolonged ANA, which is expected given her background of warfarin use. However, over the next 24 hours, there was worsening of coagulopathy with the INR peaking at 9.9 and peak proton time prolonging to over 100 seconds. The APTT was also markedly prolonged, suggestive a severe derangement of the coagulation system. Following appropriate management, but after that day, on 29 August and subsequent, the coagulation parameters showed a gradual and sustained improvement. So maybe any of the panelists maybe can discuss about this. May I know whether this pattern of coagulation profile, is it because of the venom-induced consumptive coagulopathy, or is it because of the warfarin effect, or maybe combination of both?
Hi, so I'm wondering what her regular coagulation profile is, and then we compare from there. But I would think that this is out of the range of what we can manage, and the hematology consultation is required.
Okay.
But if there's no clinical bleeding, then I suppose we can withhold the giving of antivenom if everything else is the same.
Okay. So which result that would kind of give you the idea that possible antivenom is needed from this serial blood test. These are done from the first day of arrival, 10:59, and they do it typically 6 hourly. So which one that we say, oh, okay, this might not be just from warfarin. It's the third day, the third reading, 8.04 INR from 1.69. Would that be the cutoff point?
Yeah, I think is the effect of venom.
Yeah.
Because
Yeah. So yeah, you
after
can see,
initial,
right? Very
yeah,
significant rise in INR and also all the other parameters, and remain sustained even after the fourth reading, right? Is even worse. Okay, so it's kind of a worsening trend. So what do you think, Sook Har?
Okay. Technically, like what Dr. Greg said, I would also ask about the warfarin, the dosing, and when was the last use. Technically, if we see it's possible that we are worried after this snake bite that can cause some systemic coagulopathy, which usually would be later, not the first instances with a bit of prolonged INR. From that point itself, we would have withhold the INR, I mean the warfarin already. And then when we monitor, suddenly there's a surge of the prolonged INR. I would think that probably that could be caused by the venom. And the alternatively, we probably can send fibrinogen at a D-dimer level as well to look at it.
Very good. Yeah. So at the 28/8/11/02, you probably ask also for the next sample to be sending the what do you call this? D-dimer and also fibrinogen level, right? Okay. Anybody else would like to comment? Tinesh? What do you think?
I think the question was asked earlier whether it's some kind of consumptive coagulopathy or something. Because this, even though it's a hemotoxic, so we must understand the mechanism. It has both procoagulant and also anticoagulant effect. When the procoagulant is exaggerated, then there is a consumptive coagulopathy. Somehow patients start bleeding, or you call it a defibrillation syndrome. So they consume all the whatever clotting factors needed. Then the other thing is it directly inhibit the platelet and all the other components and causes bleeding. So it works both ways. So for me, the moment the INR has been somehow static in the first two reading, when it surged at the third reading, I already start be more alert on deciding on giving antivenom, because definitely coagulopathy is one of the main indication for antivenom. So when I see that, I think we should start a bit more jumping on it. And when the other result is already high, so this is already a very clear-cut indication to give an antivenom to the patient.
JD? Do you have something like this featured in Philippine?
Actually, some of our pit viper bites would actually have undetectable readings, sometimes of PP. So this is actually very interesting because in just a day, it seems that, I mean, it's different from what we see. It seems that the coagulation is actually somehow slow. But technically, you always correlate this clinically with the progression of the swelling as well. I'd like to clarify if the rate of proximal progression is 3 centimeters per hour. So that's actually quite fast, considering that the swelling.
But that's not that's the initial hour. But then we need to look at the subsequent hours as well.
Yeah.
And look at the trend. Is it accelerating or cruising or is it decelerating? Yeah.
That's why I'm actually clarifying.
But
So
we always correlate.
Right. So in this case, it seems that it suddenly went normal. So I assume that antivenom was given here.
Yes.
Is it?
So maybe can you highlight also go back one slide? You can we typically need to also look at the platelet level.
Right.
Okay, for coagulopathy for pit viper, because some are can cause thrombocytopenia. So you can see the platelet level remains almost the same in the first four readings, right? Almost the same. So when we see this, we think that that is a kind of a typical feature also from the Trimeresurus species to have the INR affected earlier or more compared to the platelet. Okay, so next slide. So can you tell us, was antivenom given?
Actually, in this
So the
patient,
question now is, let's say the doctor first time, the junior doctor see this patient on the first day, on the first reading. The reading is all abnormal, right? In the PT, APT, INR. So are you going to start the antivenom there on the first reading, or are you going to wait until the third reading or fourth reading? So that's the question. When was it indicated? So we think that because of was antivenom given?
no, actually.
The antivenom was not given.
Okay.
Okay, are you sure?
Yes, actually.
Okay, so no antivenom was given actually for all. So this is interesting kind of a development suddenly drop just like that. So we are actually looking at maybe the worsening in the systemic because the patient on warfarin. So the question we asked, did they stop the warfarin or not?
They do stop the warfarin initially.
Yeah. So they stopped the warfarin?
They do.
Yeah, okay. So until when was the warfarin stopped? So this is the first day and then the second day, right? So after then, the third day it starts to go down back. Am I right? The INR, you can see after stopping, the INR is coming down. So whether it is a worsening of the warfarin from the envenomation, or was it just because the antivenom is actually because the warfarin is actually stopped without the antivenom? Okay. So this is the decision that we have to decide. So which one you want to do first? You want to give antivenom first, or you want to stop the warfarin first? So the decision was to withhold the antivenom. Patient is not bleeding. So this is another important consideration. If no active bleeding, we don't really have to, let's say, give blood transfusion or other intervention, even if just patient on warfarin, right? So similar approach is being utilized here. We think there could be some effect from the venom, but it's actually not bleeding, so we want to wait and we review and we stop the warfarin first. Actually, now patient is in the therapeutic dose from the venom itself from the subsequent reading. So no warfarin, but in therapeutic dose. But then it becomes a bit normalizes again to normal level, so we can consider restarting back the warfarin after that. Okay, so this is in a way quite interesting. Some people will jump to give antivenom first in the beginning, and then maybe looking at jump again, giving antivenom on the second day. But then from the REX consultation, we are a bit more pragmatic and prudent. So we said, oh no, we stop first the warfarin and see what happens. So this is what happened after that. So quite interesting. Okay. So no antivenom was given.
So in this case, was there progression of swelling? I mean, the rate of proximal progression
You
increase?
have the swelling, the chart of the
RPP?
RPP? Yes. That's another thing. We correlate also with the physical finding. Yes, very important. So, was the swelling in the thumb really bad or not progressing? Because it has to correlate. This one looked quite severe, but then the local finding will be very mild looking. So it doesn't correlate as well. Firdaus, do you have the RPP in the table? Is it worsening? The vital signs and so on.
I don't have the specific RPP, but the swelling is subsiding like towards day 4 and day 3.
Okay. But there should be a table actually. You could take from the case. Anyway, so it is not worsening lah. Okay.
Maybe that's also a contributing factor. That's why antivenomous withhold.
Yeah, so it doesn't correlate with the physical finding in a
Right.
way. And progression. So, yep. Okay, next.
The further investigation, the venous barkless is within normal range. And this is what has been managed so far in this patient. So this patient was admitted the meeting for close observation, given the risk of delayed envenomation effect, particularly coagulopathy. She was placed on continuous monitoring with regular vital sign assessment. In addition, hourly RBP and PSP were instituted to monitor for local progression of swelling and pain, which could suggest worsening envenomation. Serial blood investigation were planned, including repeat full blood count, coagulation profile, and creatine kinase to detect any evolving coagulopathy or muscle injury. And so far, the patient is improving. And for symptomatic management, the patient was given IV trauma, 50 mg stat for analgesia, and IV Maxolon, 10 mg stat as an antiemetic. And the right upper limb was kept rested and slightly elevated to help reduce swelling and minimize occult complication.
Okay. How long was the patient in the ward?
Patient was in the ward approximately about 5 days. Yeah, 5 days.
Okay.
I have a question. How long was the patient on tourniquet? I have a question. How long was the patient on tourniquet? Isn't it that tourniquet was applied?
I think on your second slide.
That's also interesting in a way because some of our experiences, there's actually really progression of swelling with tourniquet use.
It's actually from the point where the tourniquet is applied, right? So
Right.
you can see the
So 1
distal
hour
part.
there, so 1 hour,
Yeah,
1 hour.
1 hour.
1 hour after. So
But then the tourniquet application, typically, if there was a swelling due to the tourniquet, it's only on the distal to the tourniquet. Once you remove the tourniquet, it will subside and does not progress beyond the tourniquet level, the swelling, if it is just purely swelling because of the tourniquet.
Yes.
The envenoming will continue progressing if it was due to the envenoming, the swelling, even after the tourniquet was removed. So basically, the tourniquet worsen the swelling that might be caused from the envenoming.
Right.
Okay. Right. Okay. So can we move on to the next case? So I guess the getah betik or the papaya sap doesn't work, right? Or it worked tremendously well. Case 2, okay?
All right, so let's move on to case 2. So this case involves Mr. M, a 17-year-old Malay male weighing 67 kilograms, and he's a Form 5 student studying at MRSM Al-Ghazah. Previously, he has no known medical illnesses or drug allergies, a non-smoker, and his COVID-19 vaccination is up to date with negative RTK test.
Al-Ghazah is in Malacca.
Yes. Yeah. All right. So for the presenting complaint, he presented with a sudden onset of bilateral lower limb numbness and weakness, which progressed to the point that he was unable to walk independently. So of note, the patient reported consuming prawns, which he described as udang masak kunyit, approximately 3 pieces during lunch at the MRSM dining hall on the afternoon prior to presentation. Approximately 5 hours after injection, while walking with his friends, he experienced sudden onset numbness over both lower limbs, starting from the ankles, and was associated with subjective feeling of heaviness. This was then followed by weakness, causing him to fall onto his buttocks. However, there was no loss of consciousness and no head injury reported. He was then only able to stand with assistance thereafter. The symptoms persisted overnight and he remained unable to ambulate independently. As there was no improvement, he then was presented to Hospital Alor Gajah the following morning, which was approximately 30 hours after the suspected exposure. So at this point, the question is, what are the histories that is important in this case of a 17-year-old presenting with acute lower limb weaknesses following recent prawn consumption? So any of the panelists are welcome to answer the question.
Was he the only person who came down with such a set of symptoms after eating the prawns?
Yes, from the school, he's the only one who has these symptoms after consuming the prawn.
Is there any previously similar history after ingesting similar food, or any other food taken with the prawn? Is it the prawn or is it something else that he took? So those are the things I would like to know. And other allergic signs, if there is any allergy, if the patient has any itchiness or shortness of breath, chest pain, or any palpitation, or other associated symptoms?
All right, so to answer the question, then maybe we can move on to the next slide, which is the associated symptoms.
Can we go back just one slide? Go back first. So how would you like to give your find? You think it's poisoning?
Also, I would like to ask, it's like from the school, where's the source of the seafood that let's say, is it like from the canteen? Where's the source of the food? Is it
So this one is in MRSM is a residential school. So most of the food are taken in the
supplier? Where do they get? The
yeah,
supplier would like to know where they actually
yeah,
got it.
but then this is everybody else ate the same food. Is it, moderators, Fazana?
Yes, Prof. Everyone ate the same sauce.
Yeah. So this is typically a cafeteria where they serve food. This is a residential school. Yeah. So they have a lunchtime. So this is what, taken lunchtime? During lunch, right? Yeah. Okay.
I have a different perspective, but
Okay.
is there a history of hyperthyroidism in this case?
17 years old at the moment, no. Oh, well, why, can you explain why you think of a hypothyroidism?
Hyper.
Hyperthyroidism, sorry.
Yeah. Well, like if you would actually ask me, I would rather think of something like, um, especially if he's the only person who had this kind of weakness. I'm not if the question is this really poisoning? Yeah. I'm not
Yes.
yet fully convinced that
Uh-huh.
this is actually poisoning, but I've actually also tried to look into other factors that can actually contribute to bilateral lower limb numbness and
Yeah.
weakness, but particularly hypokalemia.
Yes.
So, what I experience usually for some poisoning is that there's actually facial involved. They typically start with periorbital tingling and numbness, followed by central weakness.
Okay.
So I mean, the pattern of neurologic signs and symptoms does not typically correlate with what we see.
Okay. So quite interesting differential. Greg, following up from your earlier question, I know you have a burning question to ask. So what do you think what's playing on your mind? Are you going to, prawns, right? Prawns, right? The patient keep on the whole idea here that give us kind of a lead is the prawns.
Yeah.
So what do you think? Yeah. Have
I
you
don't
had
know,
a
but
prawn poisoning?
he's the only person who has it. So
Exactly.
so it's not
Yes.
likely that it's due to the prawn, but If it is due
Yes.
to a toxin, then you could think of a tetrodotoxin or something like that.
Yeah. Okay. But
But it
didn't
should affect
say
other people as well.
exactly. Yeah. Even if you cook the fish that has tetrodotoxin, it might contaminate other things that's cooked with it, right? So very unlikely. So it's a bit suspicious, right? The history, because he adamantly uh, placed the prawn as the
Yeah, the
source
prawns, the
for his
prawns.
symptoms, right? So we
Or
always have to think, do we get ever poisoning from prawns? Have you in Philippines? You eat a lot of seafood?
oh well, if there's actually heavy metal content, why not?
Yeah, so heavy metal, it takes a while. It takes a while to accumulate, right? So it's not
Yeah,
just
but
from one.
if
Yeah,
it's so contaminated that just
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 from
the
three prawns.
three prawns, I don't think. Yeah.
So things doesn't match up here. So that's why specialists always have this,
Oh,
antenna.
was there history of diarrhea or cough in the past
Ah,
2 weeks?
no GI
GI
symptoms.
or lung infection in the past that can probably, GBS
Mm.
is also a
Mm.
differential.
Yeah. Okay. Fantastic. So this is the thing that already starting to count. There could be something else other than what he is training us, and the symptoms is from proximal from distal to proximal, especially from the lower limbs. So we think of other things. So you correctly pointed out. You need to know what is other condition. Maybe 1 week ago he has a UITI or something like that, right? Might predispose. Now only is going to be manifested as the weakness. So GPS is definitely going to be big in our mind. So anyway, let's see how this case unravel itself. Can we see the next slide?
All right. So for the associated symptoms, this patient has been feeling feverish for 1 day associated with runny nose, nauseous, and also left-sided headache's, which has been resolved. However, there was no shortness of breath, no chest pain or palpitations, no urinary or bowel incontinence, no upper limb weaknesses or numbness, no slurred speech, diplopia, dysphagia, no seizures, no rashes, joint pain, oral ulcers, and hair loss. For past medical and drug history, he has no non-medical illnesses, no known drug or food allergy, and no illicit drug use. And for social history, no recent trauma, no vigorous exercise or infection, no recent travel, and also he lives in the hostel, and the family is living in Sungai Udang, Melaka. So upon the examination at emergency department, the general condition, he is alert, conscious. Vital signs, blood pressure is normotensive. But there are a few episodes of hypertensive blood pressure, which is 143/94. Heart rate ranges from 80 to 91 beats per minute. Respiratory rate is normal. Temperature is normal, and also SpO2 is normal as well. Moving on to the neurological examination of the lower limbs. Tone normal bilaterally. Power, hip flexion and extension is 4+5. Knee flexion extension 3 to 4 and 5. Ankle dorsiflexion, plantarflexion scoring 3 to 4/5. Reflexes, patella reflex is normal. Ankle reflex is absent bilaterally despite reinforcement. Plantar response is downgoing bilaterally. Other motor findings, no clonus, fasciculations or muscle wasting observed. And for sensation, he has reduced sensation in both lower limbs up to just below the knees bilaterally. For upper limbs, all are normal. Cranial nerves and cerebellar function, all are normal. Other systemic examinations are also all normal. For his lab investigations, his full blood count, HP, white blood cell platelets are all normal. Renal profile, LFT are also normal. However, liver function test, there is a markedly elevated ALT and total bilirubin was mildly raised. However, albumin was normal and this is suggestive of hepatocellular injury. Otherwise, all are normal. For his ECG, there is sinus rhythm, T inversion in lead 3, and no conduction block. And also for lumbosacral X-ray, it was normal, no fractures or no vertebral abnormalities detected. So in summary, the labs and imaging shows isolated hepatocellular enzyme elevation without systemic inflammation or renal involvement, no structural spinal pathology supporting a neurological rather than musculoskeletal or systemic cause for the acute lower limb weaknesses. So the question here is from the history, physical examination, and labs, what might possibly be the cause of his lower limb weakness?
CBS.
Okay.
I agree with Dr. John that actually there are few things pointing towards I think the so-called shellfish tu macam is like a decoy for us to, because everybody consumed the same thing and only one person came with that symptom, and also there's a bit of autonomic dysfunction in this patient where you see the BP has been quite fluctuating and the absence of deep tendon reflexes. What doesn't fit the puzzle is actually within a day of the upper respiratory tract infection, the patient developed the symptom. That part is a bit doesn't match the puzzle there, but it's still possible for patient to develop GBS there. That's my opinion.
Yeah, I mean, this is just history from them, so it might have actually the earlier symptom but did not pick up, maybe was overlooked. Yeah, but it doesn't have to be a URTI symptoms to develop GBS, right? So,
Yeah, I think.
Great. Maybe Sook Har. Does he have any past history of diarrhea? That can also another source. Doesn't have to be just URTI. So any source of Campylobacter jejuni, tapi not really that. Itulah, we did not ask if they have history of diarrhea also, or taking any other risk factors, for example. But then not in this young man, 17 years old. So the symptoms is quite progressive, very rapidly lah, the weakness, right? From not able to walk. So he doesn't say any there's any paresthesia also. Did he say any paresthesia? No, right? Sensation is intact.
The
So,
sensation is not intact for the lower limb.
okay.
Reduced
So that
sensation.
is
Yeah.
reduced sensation lah. So what do we do next? What do you suggest we do in terms of how to maybe bring out from our red herring of poisoning from prawns to managing this case? So this is very important, right? So we thought initially our junior doctor say poisoning from prawns, right? So how are we going to change this diagnosis now? Greg, what do you do typically?
Well, it might be possible that the patient has transverse myelitis.
Okay, could be.
A
Yes.
lumbar puncture might be needed.
So maybe we want to do further investigations that try to look for these symptoms of muscle paralysis, right? Muscle weakness, yeah. Not just about poisoning anymore.
So numbness, is there a level where the numbness where the numbness starts?
For the numbness, no, but it is restricted. Back one side. Yeah, it's set up to just below the knees bilaterally, but where it starts, it doesn't specify.
So L3?
Could be. Knees, below knee, right? The power also reduced, right? Only on the lower limb. And it's a bilateral. So, yeah. The spinal. Okay. Right. Any other input? Maybe anything, Greg? I think you want to do a lumbar puncture? Wow.
Yeah, maybe MRI before the lumbar puncture.
MRI, yes. Okay. Okay. See, straight away lumbar puncture. I said, wow. Okay.
MRI first, yeah.
MRI, okay. I agree. We do non-interventional, ni dulu. Okay. So,
Maybe an EMG and TV.
possible. What else you want to send for GPS? You want to confirm?
Antibody testing.
Yeah, immunotherapy. Yeah, okay. So, do you have any intervention for GBS in Philippines or Singapore? We do intravenous immunoglobulin. Is there? Or you do plasma exchange? Sook Har, how do we manage GBS?
IVIG, if let's say the precipitating cause treat the infection, if we can find some of
The
them.
IVIG, do we have the IVIG in Malaysian hospitals?
Yeah, we do give
We
IVIG.
do. Okay.
Yeah.
But that's only for severe case. We observe dulu kan. Typically, we just observe first and manage conservatively first. And see if it's progressing worse, then we start the IVIG. Okay. All right. Lagi, anything else? It can be for a few weeks, right? It can be prolonged, right? A few weeks, the symptoms. So, close monitoring progress of motor function, especially the respiratory lah. So this one is only up to the buttock level. Unable
I
to
think
walk.
in this patient, quite a clear indication to start early IVIG in sense of
Yes,
rapid
very fast, right?
progression.
Rapid
And
progress.
also there is already some signs of autonomic dysfunction. So in this patient, patient could benefit from IVIG, bro.
Yes, I agree. It's quite rapid lah, the progress. Okay. Okay. Anything else that we might miss?
So actually for this case, what was done is he was admitted for close observation and he was given IV normal saline at 1 cc per kg per hour. Urine output was monitored, serial neurological examination was done, and he was monitored for his respiratory status, and also he was referred to neuromedical for early neurological input. So is this management appropriate, or is there anything that maybe the panelists would like to add on?
So this is from the emergency department, right? Not in the ward. Do you have any information about how patient progress in the ward? No. No. Okay. So how do we differentiate between viral and also non-viral causes? Do we need to send CNS? Would that be helpful? No. What do you think, Greg?
Sorry, I didn't get that question.
So most likely is a viral cause, but if it is bacterial, do we need to possibly send culture, blood culture, or not?
I don't know if there is any sign of infection.
Yeah.
Yeah, botulism, but that will be a somewhat more cranial nerve involvement.
Yes, that's higher up, right? So it's not.
And it won't be one person. The whole the whole cafeteria might kena.
Yes, exactly. Yeah, we have a recent experience also with somebody came for tetrodotoxin poisoning from eating a crab. Maybe we'll discuss about it in the next one. It's very interesting also. Okay. So, okay, I think that's it. I think this is okay, right? So far. So we change our diagnosis. So if we change our diagnosis, what would we change it to? Any idea? Any suggestion? Lily?
Poisoning unlikely.
Poisoning unlikely.
Prawn
Prawn
poisoning
poisoning
unlikely.
Okay. But what is our working diagnosis now?
Well, actually, I would still entertain the possibility of Guillain-Barré syndrome.
Okay. Muscle
I think
weakness,
we
very
can put
costly.
as bilateral ascending paralysis to rule out GBS for now, and unlikely shellfish poisoning.
Okay. Okay. So how? Any idea of, are you okay with that diagnosis from Tinesh?
Yeah, I agree with that.
Yeah. Okay. Greg, are you okay with that? Or you want to add or change?
I have one crazy thing to say, and could this be a unrecognized banded crate envenoming?
Very unlikely because no history of contact with snake. One. And the weakness is ascending. If it's a snake, is typically descending. You see the ptosis first, right? Yeah. So no mention about ptosis in this case as the first presentation or early presentation. Yeah, very unlikely lah from snake bite. Okay. So that's our input. This is an interesting red herring case, right? How we deal. Sometimes our junior just stick to history only and not thinking be outside of the box. So it can even transfer the diagnosis to our colleague in the medical and then even beyond that. But then it's not correct diagnosis. So it's very important that we have to think outside the box if something doesn't match some of the thing. That's why history here plays a vital role for us. As Greg was pointed out, only one person poisoning, unlikely. You eat a lot people in canteen, there should be more people having an outbreak of poisoning, right? So if it was, and then the second is muscle paralysis from prawns, very unusual also. I never come across eating prawn causing neurological symptoms. No matter how the prawn is catch and so on, whether there was a red tide or not, but we have not really encountered such poisoning. And this case happened in Malacca. And Malacca shore, I think at the time there was issue with shellfish poisoning issues as well. There were red tide in that area. So, but those are shellfish. Prawns and fish typically do not have issue with this because they are not filter feeder, right? Okay. All right. So anyway, maybe next question. Do we have time for last question? Last case, maybe it's 422.
Yeah, I think this next case is quite a short one, so maybe we can just go. So for case 3, we have a 4-year-old boy with no non-medical illnesses or allergies playing at the beach in Teluk Kumbar. At around 6 p.m., he
Where
suddenly...
is Teluk Kumbar?
Teluk Kumbar is at Bayan Lepas,
Where?
Pulau Pinang.
Penang. Okay, in Penang.
Okay,
Penang Island.
Penang Island. At
Okay.
around 6 p.m., he suddenly cried in pain when his right arm became entangled with jellyfish tentacles. His mother then removed the jellyfish but was unable to identify the species. Immediately after the accident, the child complained of localized pain over the right upper limb. Vinegar was poured over the affected area by the mom. There were no systemic symptoms such as shortness of breath, vomiting, abdominal pain, or diarrhea reported. So just like and then a number of bites unsure, and he was then referred to hospital Balik Pulau for further management lah. So here, to start off the discussion, maybe we can know how common are jellyfish stings in our region, and what are the most medically significant species that we should be aware of for jellyfish.
Is there a picture of the sting, the affected limb?
Alexa, to slide. Yeah, here is the pictures of the limb of the kid lah. So if you can see here, there is a minimal swelling over the right elbow, which improves with time. Not warm, not tender, no active bleeding. Pulse is still palpable. Sensation is still intact. CRT is less than 2 seconds. Warm peripheries and also compartment is soft. And also, I would like to ask that the mother poured vinegar on the sting site. So may I know that what is the indication or what is the benefit of the mother doing so?
Okay, interesting. So you can see the extensive skin marking, right? So is that a typical what type of jellyfish do you think can cause this marking? JD, you are an expert on jellyfish. Mr.
Although
Caronex.
although it's not that's what I asked actually the specific picture of the limb because there's actually a typical pattern of injury for
Yeah.
Chironex, box jellyfish.
Yeah.
So
So do you think this feature will last like this until the end, or will it change, or is this a very acute presentation and you can see a lot of inflammation as well, right? Then some swelling.
yeah,
So as we progress, the feature will change after 24 hours or 48 hours.
right.
Yeah.
Although
So
me
it's not going.
yeah, so though sometimes if this was how many hours from the time the patient arrived at the emergency department?
He had the sting at 6 p.m.
Mm-hmm.
And then I was not sure about when he arrived at the hospital because he was referred to the GP first, only then to the hospital ED department.
Then it was there's that they transfer because sometimes uh in very acute incident you cannot see the discoloration yet. You'll just see like red markings and wheals. And after some time, maybe I can observe like 6 to 12 hours, it will actually hyperpigment. And you will already see the typical frosting ladder pattern for box jellyfish. So the vinegar is actually one of the things that would actually help inactivate the nematocyst. And this has actually been decided upon, at least for the regions within the Western Pacific, so including Malaysia and our country, that vinegar will be most beneficial, especially for these kinds of jellyfish envenomation.
What about the use of topical lignocaine, for example? Is that kind of more superior than vinegar for this case?
Although I think the purpose of application of topical lidocaine is actually different from the application of vinegar, but both actually have roles, especially for the application of vinegar, lidocaine rather, it can actually address the pain.
Yeah.
There's actually there's a randomized control trial on how pain is actually addressed in some controversies for box jellyfish. And they found that the Australians would actually advocate no difference between hot or cold. Then there's the application of lidocaine in addressing pain.
So the lidocaine has analgesic effect, right? So it stops the nematocyst from discharge, and also at the same time the skin is raw looking, so it kind of a local analgesia. But if we put vinegar with the raw skin as well, that can cause more pain from the vinegar, though it stops the nematocyst from discharging. Okay, so that there is a kind of valid. The other thing is that I think at that moment in time on the beach, people have more access to vinegar compared to lidocaine spray, unless you have Baywatch on standby and they have lidocaine spray, or somebody carry jellyfish sting kit that might have lidocaine spray in the kit. We are looking at that at the moment to have these kits for patient or people going to the beach. Besides that, anything else that we should consider for this patient? One of the effects of Chironex envenoming. So we don't know which species, right, at the moment. What else can we do to help in identification? Do we have ways to try to identify just from this? skin sampling, right? We can use the skin sampling for the nematocysts. Look under microscope. Use cellophane tape, apply it over the stung area, and then remove it and put on the slide and look under the microscope. You will see this typical cigar-shaped nematocyst. Okay, that may point to chironex species lah. Okay. The other thing is that patient might have a cardiac issue. So ECG perform early, ready to standby, resus trolley, besides patient. You might have to intubate the patient and do CPR. Okay. So anything else? Input, Greg? Singapore also have box jellyfish now. We found box jellyfish in Sungai Muar, nearby on the south. So it's quite interesting.
Yeah. It's quite
Because we have,
remarkable.
yeah, yeah. Sorry. Go ahead.
Sorry. Yeah, I think it was quite remarkable. The mother carried vinegar to the beach.
Yes. So we have a campaign. Bring vinegar to the beach, either for your mee goreng or for box jellyfish. Okay. Yeah, another issue, as you know, this is a public health issue, right? So awareness on public health and so on is very important, how we give the information, and also what we can do to help in terms of alert the public when we have this, you have to have the signage about the danger. And now we are campaigning on prevention is better than cure. So rather than bring vinegar, we ask them to wear proper clothing before going to the sea, into the water. So children, particularly like this, can wear the lycra suit, very light, but it prevents the stinger from discharging when in contact. So whole body suit, meaning that from head to toe, from neck to toe, or some with hoods as well. So this is another area where potential for business who wants to sell a swimsuit for the beach. Okay, places like Langkawi, we had a recent death of 2 years old. We discussed this, I think, in the last day. And then we have even adults got stung, and now this child in Penang. So Singapore, I'm not sure, but I don't know. I think they have identified also in somewhere near Sentosa area. They found this box jellyfish as well. But there is, I think, an issue with possible translocation of specimens from area that is endemic to area like our waters because of the ballast water from the big ships. So they suck in water from somewhere that has box jellyfish, and then they carry with them to, for example, Singapore, a lot of shipping, Penang also, and then they release the ballast water, then they will introduce the jellyfish into the area. So that's one theory why we have. But from our research, biologists research in the Langkawi in Penang area, that apparently already an endemic area near the mangrove forest where they have breeding ground for this box jellyfish as well. So it's already probably there a while, and that could be seasonal, but then the ballast water release could be any time of the year. So yeah, so we are hoping to do the survey as well in Langkawi because we had the recent death. I think Sabah and Sarawak, I think Sabah near border to Philippines, we have established already of this species being local. So yeah, quite interesting. Okay, thank you so much. Anything else you want to finish off before we go to the Kahoot?
Yes, so just for the management, he was monitored for vital signs and given syrup paracetamol for the pain, and he was monitored for any anaphylaxis reactions, for any development of pain, numbness, and digital ischemia, and also nematocyte sampling was done for this patient. The question is, what are the red flags that in jellyfish stings that it indicate the need for us to escalate the care for the patient.
What do you mean? Meaning go to ICU?
Maybe
Or
because maybe closer monitoring or
I think closer monitoring is from the beginning on arrival already. So that is a continuous, must be close monitoring of vitals and also ECG because it affects the heart, okay, envenoming. And the thing is about jellyfish venom is quite short acting. It's not like snake bite can be like the pit viper can be up to 2 weeks issue. You can get envenoming from that. But jellyfish sting, from our experience, also is very, very, very quick, very short, less than 6 hours. The symptoms will present. Some are very fast. Actually, after even a few minutes after stung, they already have a cardiac issue, depending how fast it's kind of travel to the heart. Yeah. Okay. So anaphylaxis. Do you think anaphylaxis is an issue with jellyfish envenoming, JD?
Well, I know of someone allergic to jellyfish, but I mean, some will actually always dismiss some deaths occurring with jellyfish as anaphylaxis reaction. But I'd just like to emphasize that again, box jellyfish contains very deadly cardiotoxins and hemotoxins that can really impair the heart and give you cardiac arrhythmias on an instant. So that's it.
So I think the issue of anaphylaxis, you have to have at least exposure to a previous sting. So you might have, when you were swimming before, you might have already got stung, but you know, very mild, minor.
Or
but
you
you're
might,
already,
or you're
already,
eating.
huh?
You're eating jellyfish.
Oh yeah, eating jellyfish, really?
It's a Chinese
Okay.
delicacy. It's a Chinese delicacy.
Okay. Do you get anaphylaxis from eating jellyfish?
I know one.
I haven't encountered before.
Yeah.
So,
Recently, he took the Chinese jellyfish and then suddenly he needed
okay.
epinephrine.
Interesting. Okay. So, okay. So that's it. Any final words from our panelists, Greg, Tinesh, Sook Har, before we move on to the quiz?
No, Prof. Thank you.
Okay, thank you.
All right, thank you to all the panelists, Dr. Ong Sook Har, Dr. Gregory Cham, Dr. John, Dr. Tinesh, as well as our advisor, Prof. Khaldun, for sharing your expert opinion in the clinical management of toxin-related diseases during our case discussion just now. We have prepared a quiz for the audience. So Prof. Khaldun will share a Kahoot quiz. Please scan the QR code or key in the PIN number to join the quiz.
Number 3. Number 2. And champion is...
All right, thank you so much, Prof. Okay, to the winner, Prof. Khaldun actually have prepared a big prize for the winner. So please contact Regina if you know, or if not, you just text in the box. Okay?
now we would like to present e-certificates to our panelists as a token of appreciation. So first, we would like to invite Dr. Ong Sook Har to receive the e-certificate. Yeah, maybe you can just smile, we'll take a picture. Oh, okay, it's okay. You don't have a camera.
Sorry, because my camera.
It's okay, it's okay.
Thank you so much.
Welcome. Okay. All right, next, we would invite Dr. Gregory Cham. Okay, I'll count to 3 and then we take a picture. Wait. All right, so smile. 1,
You look younger lah.
1, 2, 3. All right, thank you. Next, I would like to invite Dr. John. All right, smile. 1,
This
2,
is like 18-year-old
3.
teenager John David Comandante.
Okay, and last but not least, I would like to invite Dr. Tinesh.
So
All right.
this is the most gung-ho one. I think
One, two, three.
the next James Bond.
Okay. Thank you again to all of our panelists for the valuable inputs throughout the case discussions. Also, thank you so much to Prof. Calvin for assisting and moderating the session too, and also for the inputs.
Okay.
Okay, so moving on, I would like to invite Dr. John to give us the closing speech. The floor is yours, Doctor.
Hi. Good afternoon to everyone. So as we conclude this session, clinical toxinology, is it relevant to medical students? Episode 5, season 5 and episode 2. First, I'd like to extend my sincere appreciation again to the organizers, Dr. Khaldun, for once again inviting me to be part of this important academic webinar. It's always been an honor to participate in such forums where we will be able not only to share perspectives but also learn from each other in the spirit of collegiality and regional collaboration. Today's discussion really underscored the importance of introducing clinical toxinology at an early stage at medical education. Like, for our countries like Southeast Asia, um, particularly Malaysia, Philippines, once participating here, Singapore, this is very relevant. Our geography, our biodiversity, the environmental context, the places where our communities in regular contact with a wide range of toxic exposures, including envenomation, poisonous plants, and other naturally occurring and man-made toxic hazards. This reality actually highlights the need of medical students to be equipped in their training with the foundational knowledge and clinical awareness to recognize, manage, and prevent toxin-related conditions. I'd like to convey my sincere thanks to Dr. Khaldun for his steadfast support of this event and for his continued encouragement of the initiatives in the CREX. Such leadership and commitment are invaluable in advancing collaborative educational efforts across the region. And to all of our speakers, participants, and organizers, thank you for your valuable contributions and active engagement. We hope that today's session will further encourage the integration of clinical toxinology in the medical training and strengthen our shared commitment to building a more responsive and better prepared healthcare workforce for Southeast Asia. With this, maraming salamat. Thank you very much and good day.
Maraming salamat po. Okay, see you in KL.
All right, thank you so much, Dr. John. So before we end our webinar, can I have all the panelists, Prof. Khaldun, and both of us to open the camera? Let's have a quick photo session together. All right, everyone ready? On my count. Okay, 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 3, 3, 3, 3. Okay.
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 All right, so we have come to the end of our webinar today. To all participants, please scan the QR code to fill in the feedback form to receive your e-certificate. You may also click on the link in the chat box to fill in the form. Once again, we thank all of you for joining us today and we hope you have learned something about clinical toxinology. See you in the next episode of Clinical Toxinology. Is it relevant for medical students? That's all from us. Thank you and goodbye.
Thank you.